Am I recording?
I did? I'm sorry.
I think so.
I'm okay, thank you. Yeah.
I think you said that it's a bottom arrow. It's kind of weird. It's this
Oh.
there, yeah.
Yeah, hold on. Can I stop the sharing real quick? So that word it. Okay.
That's so embarrassing for you that you don't sit there. I totally think my job.
How do you make
Sorry.
Dude, I don't even know how I ended up. I was like, I went to after we studied, like, we got food and like met it was law school fun. And like we just had one beer and then the next day I know it's like 3 a.m. Fucking. Yeah, I don't know how it happens. It's like well, you
What brings you around?
oh, I had to see the goal, man.
Go. Embarrassing. Don't ever say that.
Wow, I just saw it there.
You have a MacBook charger by any chance?
Yes, the magnet charger.
Yeah. All right. Wait. I have one.
So we're really grateful to have Peter here. He with his busy schedule. We're just gonna go over some basic concepts of proximal humerus fracture. You'll see some stuff about what's gonna be on your exam Thursday as well. So Peter.
Sorry. Hey guys.
Okay.
Just setting this up real quick. This without the charger.
That works sometimes.
Yeah. Okay. Gonna work on mine. That's okay.
That's what tomorrow.
Okay. Hi guys, how's it going? Thank you for having me here today. I'm not really a good speaker, so I apologize in advance if this sucks, but hopefully you guys could learn a thing or two. We'll kind of keep this casual, just more so mostly M1s and 2s here, right? Yeah, everyone, and no 3s, right? Okay, cool. Yeah, so I guess a lot of you are interested in orthopedics or at least kind of thinking about it. So I think this is a good start. The bread and butter of orthopedics is learning how to manage fractures. And before you get to the part where, you know, you're making decisions on how to treat a patient, you have to at least learn how to assess a patient, how to look at imaging, how to do an exam, things like that. So that's kind of the purpose of what we're going to do today. More so focus on how we think overall broad concept about fractures in general. And then we'll kind of talk a little bit about treatment, but that's not really the scope of this lecture. Okay. I guess they wanted you guys to fill out a survey. You guys all, everyone got this? All right, cool. All righty. So I heard you guys have an anatomy or some exam tomorrow for the M1s. So they wanted to start you guys off with some new world. Who wants to read this for us? Anyone, just shout it out. Go for it.
A 25-year-old man comes to the office due to right arm weakness. The patient injured his right shoulder several months ago in a motor vehicle collision and has had difficulty raising his arm since. On examination, there's diminished pinprick and temperature sensation over a small area in the right upper lateral arm and prominent atrophy of the right deltoid, 3 out of 5 strength on right shoulder abduction. That's abduction. Reflexes and hand grip strength are normal in the upper extremities bilaterally. This patient most likely injured which of the following is the nerves?
Okay, so they're kind of alluding to what we're talking about today. So this patient most likely has some sort of injury in his arm, right? And now he's presenting several months later after that injury occurred, and he's got some nerve deficits and some motor deficits. Okay, so hold on to this question. I guess we'll come back to it at the end of the lecture. Okay. So just broadly speaking about proximal humerus fractures. Okay, so these are fractures that we tend to see either in two different sets of populations. The elderly will typically are more frail and you see low energy mechanisms, or more commonly, you could see them also in the younger population in kind of high energy mechanisms. And you guys get the difference between like low versus high energy. Like what's an example of a low energy mechanism for a fracture?
Fall from standing height.
Yeah, a fall from standing height, right? Versus a high energy, you think about things like motor vehicle accidents, motorcycles, which I see 20 times a day on orthopedics. But yeah, so most fractures that you'll see kind of have some sort of demographic split up either by age range or by sex. And typically the fractures that we see more commonly in the elderly will be more common in which gender do you guys think? Females, right? And why do you think that is? Osteoporosis, right? And the effects of estrogen. So that's a risk factor for these types of fractures. Most, again, they're about 5% of all the fractures that we see in orthopedics. And they're pretty common in the elderly. Third most common if you exclude vertebral fractures within the spine, okay? We'll talk about, what type of fracture pattern there are and which ones are most common, and we'll take it from there. But for just kind of describing the overall spectrum of them. When you have a proximal humerus fracture, where is that referring to? So what do you guys think the proximal humerus entails? Okay, surgical neck. What else do you guys know about the proximal humerus? Are we talking about here, like broadly speaking, where are we referring to, right? Upper third, right? So you have the proximal humerus, then you have the humeral shaft and distal humerus, right? So whenever we're talking about proximal humerus fractures, we're talking about everything near the humeral head and that articulates with which other bone in what joint? The glenoid, right? So it's the glenohumeral joint. So that's exactly where we're talking about today, okay? So anatomic locations we'll talk about a little bit more, but there's different pieces within the proximal humerus that we refer to within that anatomy. And you could see different fracture patterns. A two-part surgical neck fracture is kind of the most common, and I'll show you what that looks like in a little. Risk factors, we kind of talked about elderly osteoporosis, female gender. Why is it epilepsy up there? What do you guys think? Falls, okay. General epilepsy, right? What is that? Seizures, right? So people who have seizures actually commonly have shoulder injuries, so it's something to be aware of. That can include anything from shoulder dislocations to fractures, because kind of when you're seizing, if who's ever actually seen a seizure in person, it's pretty a lot of you guys have. So it's especially the tonic-clonic seizures where patients are completely, out of control and they're spazzing. A lot of them, even if they're like laying down, it's not necessarily a fall. It's a lot of repeated impact to the shoulder area more so than anything, okay? So if you have epilepsy, which is kind of repeated seizures over time, it's uncontrolled, you could have recurrent stress and kind of impact injuries at the shoulder. So that's kind of why it correlates. It's not to say that everyone with epilepsy is going to have a fracture or dislocation, okay? So then this is what we're talking about. So osteology, we're looking here at the bone itself, right? So if you imagine, are we looking at the left or right side based off this diagram?
Right.
Are we? Yeah, it's a right side. Exactly. Go with your gut, always go with your gut, right? So if you're looking at a plain film, which we'll look at some later, right? Everything's facing the opposite, right? So if you would imagine, this is a right shoulder, right? And this is your humerus and the glenoid would be here, right? So it would be, the glenohumeral joint would be articulating somewhere about here, okay? So some of the things that we need to understand is the humeral head, obviously. This is the shaft that we talk about. So we're looking at everything proximal humerus fractures, proximal third. Any fracture through the shaft is treated differently, and it's a whole different, lecture and outside of the scope, because the way we treat a shaft versus a proximal humerus is completely different, okay? Because there's different considerations for each fracture. So that's another thing, obviously it might seem rudimentary, but if even within the same bone, different parts of the bone are classified as different fractures and we approach them differently, okay? So it's not even someone, a classic example of this is, the femur. The femur, you could fracture it in several different places. And even within, the femoral neck, exactly where in the neck could completely change your management of how you treat a femoral neck. So kind of basic orthopedic principle is that we don't just refer to the bone, but exactly where in the bone. We have to be as descriptive as possible whenever we're talking about fractures, okay? So humeral head, proximal third, there's two things that we always look at. There's the greater tuberosity, which is where the humerus, is it medial or lateral? Lateral, okay, right? Your greater tuberosity, and your lesser tuberosity, it's actually more anterior, okay? Because if you think about it medially, that's where your joint is. So it's not there. The lesser, sometimes people think because the greater tuberosity is, lateral, that must mean the lesser is medial. It's not exactly, it's more medial, but it's on the anterior surface of the humerus, okay? Right next to it is the bicipital groove where the biceps tendon passes. And then we have two different necks that we refer to within the humerus. There's the anatomical neck and the surgical neck. What do you guys know about the difference of these? Or what does each refer to? Take a while, guys. Not on the fly.
Just the surgical neck is like one of the most common
Yep.
fractures occur.
Yep, exactly. All right. So the anatomical neck, as you guys know, when we're born, our bones don't come out looking like adult bones, right? There's growth plates, there's different parts where the cartilage is growing, right? And over time, that bone fuses, and then you have one long bone, right? For the humerus, there's the physis occurs here, kind of at the anatomical neck, where the humeral head and then the shaft will kind of merge and fuse over time. But the anatomical neck is descriptive of where that physis used to be, all right? And then the surgical neck, like you said, is kind of this weakened area that's susceptible to fracture, just kind of because of the forces, and we'll talk about what those forces are in the next slide, how those forces act on the humerus, okay? So one thing to note of is that whenever you're looking at anatomy, it's not only important to know just kind of the parts, but you need to know certain relationships that are consistent between everyone's anatomy. So one thing is, for example, is the neck shaft angle. Who thinks they could describe what the neck shaft angle is? It's 135, but like what does that actually mean? Because these kind of things help us to, why do you think we care about normal, like, and knowing numbers like this? What does that make a difference for? So the reason we like to look at these things and kind of understand them is that whenever we see a fracture, sometimes it might not be so obvious, and you need to have certain markers that you can measure and assess kind of if you're near normal reduction or anatomic reduction or not, right? Or if you have a fracture that's kind of this, there's pieces that are not aligned and you try to get a good alignment, you need to know those anatomic relationships so that you can be able to say, okay, we're back near normal anatomy, or we've restored, you know, as best as possible, the anatomy of the humerus, okay? So the average neck shaft angle in most people is around 135, and that's the way you look at it is if you draw a straight line through the shaft, right? And then you kind of make a perpendicular line through the neck here, right? This angle from here, if you would imagine this axis versus this axis, the kind of the long way around is about 135. Okay, does that make sense? All right, so what muscles do you guys know are kind of in the ballpark of the proximal humerus? There's 4 that are pretty commonly referred to whenever we talk about anything related to the shoulder. What are they? Or what are they called, referred to when we group together? Rotator cuff, exactly. So how many muscles are in the rotator cuff? All right, spit them out. Okay, good. All right, where's the super? Good, you're ready for tomorrow. I love it. Where is supraspinatus sitting? On the top. Okay, where's infraspinatus? Okay, on back or the front? Where are we talking? Back, right? Back of the scapula. Okay, where's teres minor? Right below. Okay, and then where's the subscap? Anterior, right? Okay, so what else also kind of connects? If we're thinking musculature near the shoulder, what other muscle plays a part or a role in kind of the range of motion of the shoulder joint? The deltoid. Okay, what else?
Serratus anterior.
Okay, what else? The pec, right? So these the reason why we need to understand where the muscles are. How many of you guys looked at in your anatomy courses origins and insertions, and it's a pain to memorize all this stuff, and you you like curse out your anatomy professors and all this stuff, but it has a reason, right? Why do we care about this? Is because it plays a role in how the anatomy works, and whenever you're assessing a patient, whether it's for a fracture or for kind of some weird range of motion or limited motion, you're able to kind of, you should be able to, by your physical exam, kind of identify where things are going wrong, okay? And for you to understand that, you need to know the normal anatomy and what these muscles do, and you're not gonna, you know, there's one way to memorize it, right? Or if you understand kind of the relationships where things are attaching, then you'll understand kind of how they move the humerus in this example, okay? So where do the supraspinatus, infraspinatus, and the teres minor, all of them, they attach on one part of the humerus, where? Greater tuberosity, okay? And they're all coming kind of from where? Where are all these kind of ending up? Where's the greater tuberosity? Lateral, right? So they're all on tension and their origins are kind of in the back or the top of the scapula, where they attach here laterally on the greater tuberosity. What kind of motion do you think that brings? External rotation, right? So it's a lot of this, okay? Versus the subscap, it's attaching where? Lesser. And where do we say the lesser sits on the shoulder? Anterior, right? So if you're lesser, now if you contract, or sorry, if you're subscap, if you're contracting your subscap, what kind of motion are you doing? Internal. Good. What about your deltoid? How do we check the deltoid and what it does? What do we ask patients to do? Abduct, right? So it's a lot of this, okay? And for your step exams, they for some reason like to ask you which muscle groups are from like 0 to 45 and then up to control. So you guys, that's irrelevant here, but it's important. But for in terms of, you know, a fracture, right? So when, let's say you have a proximal humerus fracture, the way we kind of anticipate where these fragments will go is based off of what muscles are attaching to them, right? Because if you have, for example, the greater tuberosity, right? And now it fractures off of the humeral head, where do you think it's gonna go? Where? Yeah, well, a little, yeah, it's gonna get pulled laterally and posterior, right? It's gonna get externally rotated, okay? Because the forces acting on it normally externally rotate. So now if it's a free fragment, in relation to your humeral head, it's gonna be on the external side or more lateral posterior, depending on kind of how far it gets pulled back or what other things are blocking it, okay? If you look at the pec major, okay, where does the pec major attach? It's not the lesser, it's kind of in between. It's between both tuberosities, okay, so kind of between the between the greater and the lesser, okay? So if you would imagine now the deltoid, or sorry, the pec is pulling which way? If we said the greater is lateral, right? And then the lesser is more anterior and it's kind of somewhere right in the middle. Where's the pec major pulling things? Well, I don't know. It was a little moment. Where? Medially, right? So it's a medial muscle. This is your pec, right? So it's gonna, whatever it's attached to, if the attachment remains, or sorry, the insertion remains near its attachment, right? It's gonna keep pulling it medially and anterior, right? What about the deltoid? We say that, where does the deltoid attach? Hint, it's in the name. Not the greater or the lesser, it's the what? Tuberosity. Yeah, exactly. So it has its own kind of prominence on kind of the humerus kind of almost near the shaft here, but right before. So if you have the deltoid pulling, and we say the deltoid does what? Abduct, right? So then if your deltoid displaces, or if you have a fracture and your deltoid is still contracting, where's that going to pull everything? It's gonna abduct, so the proximal fragment, right? If you would imagine kind of a fracture here, if you will, so the deltoid is gonna pull this proximal fragment where? Laterally, right? It's gonna pull it up and lateral because that's what the deltoid does. It's about a lot of this abduction. Okay, does that make sense? So if I cut kind of things here, and let's say if we go back. Let's say if we have a fracture right here through the surgical neck, which we said is one of the most common locations, right? So the deltoid is going to pull this proximal fragment upwards and lateral, okay? And then we talked about the pec, and we talked about also supraspinatus, infraspinatus, teres minor. What about the subscap? Where does the subscap attach? Lesser tuberosity. Okay, so where is it going to pull that portion? Internally, right? Okay, exactly. All right. And the reason that's important is because where did we say what joint are we talking about here? Glenohumeral joint. Is the joint is on which surface of the humeral head? Kind of the medial side, right? So if you're pulling internal, that articular fragment is going to get pulled more medium, okay? All right, so those are the muscles that we have to talk about. Let's talk about the nerves and kind of the vasculature in the area. What nerves are pretty important that pass through that shoulder? Axillary nerve, okay. What else? Let's talk about nerves, for example, just for now. Okay, what else is coming kind of across the shoulder and thinking the rest of the. Okay, right. So it's the whole brachial plexus, right? All those nerves. You guys, I'm sure, learned this ad nauseum, right? All those nerves are passing through and feeding the entire upper extremity. So depending on what happens, you could have damage, and then where the fractures go and what is kind of pulled, you could have damage to some of the nerves in the area, right? What's the most common that we look at for any shoulder pathology or a proximal humerus fracture? Axillary nerve, good. In terms of the vasculature, what are the two, the blood supply for the humeral head? And the anterior humeral circle. Which one provides greater blood supply? Posterior, good. Okay. So those are kind of, that's something that we worry about, again, depending on what fracture pattern we have. There's certain types that we know have a high risk of AVN. What's AVN? Avascular necrosis, right? And that happens because of decreased blood supply. Sorry. So if you have a injury to the main blood supply of the humeral head, that's why we care about where these vessels are and where these nerves are. Because again, if I know this fracture pattern has like a 25% rate of AVN and I see it on an X-ray, then that's gonna change my management of this, fracture, because I know that this patient might not do well because they're gonna at high risk of AVN. Why do I know that? It's because I know what vasculature is in the area. So that's why it's really important to know your anatomy before everything else. I recently saw this quote and someone said, it was like, anatomy is like the ABCs of orthopedics, right? So you cannot get to anything else in orthopedics without knowing your anatomy, right? So yeah, anterior, circumflex, and the posterior provides greater blood supply. All right. So whenever we look at a fracture, we talk about a couple different things. Okay. Let's say you're the resident on call, right? And you have to speak to your senior resident or your attending, and they don't have a computer in front of them. Let's say they're at the beach or something, they're enjoying their time. You're on call here at the hospital. You get this patient, and you go see them. You look at the X-rays. They have proximal humerus fracture. Now you're getting on the phone to call your attending, or you're sending them a text. What's the best way to describe fractures? I can describe the X-ray, or what else can I do? Talk about certain patterns, right? And the reason why we have a lot of you guys may or may not have heard us, if you've come to rotate or shadow or whatever, we'll talk about classification systems for fractures, okay? And you'll hear a lot of numbers, type 1, 2, 3, 2-part, 3-part, 4, all these different, each fracture is almost every single one is associated with some sort of, fracture classification. The reason why classifications are important, one, it's educational, so we can all be on the same page and learn. But two, a good classification system should be able to describe to someone who's not looking at the imaging exactly what to see or what to expect from the fracture just based off the classification alone, right? You could sit there and, go through an X-ray and describe every single part over the phone, and that could take 5 minutes, or I could call my attending and I could say, I have a near 2-part, greater tuberosity, and articular surface fracture, right? And they'll kind of have an image in their head based off me just saying a 1-sentence, 1-liner, and that'll save everyone's time, right? And not only that, so a classification system, if it's good, should do 1, describe the fracture, right? And 2, should dictate management, okay? Not all of them always end up dictating management, but a lot of times the really good ones and why we classify things, so we could say, a 2-part versus a 4-part are going to be managed differently, okay? And we'll kind of get into this a little bit. So the way we look at proximal humerus fractures is based on kind of an anatomical relationship of 4 different parts, okay? So the 4 parts that we always look at for these types of fractures are the greater tuberosity, the lesser tuberosity, the shaft, and then the articular surface. What is the articular surface? It's this part, right? This part of the humeral head that articulates with the glenoid, right? So that's your glenohumeral joint. And anytime you talk about an articulation, right, it's where the joints meet, okay? Where the bones in the joint meet, sorry. So what makes something apart? This was described by Neer, I think in the 80s, don't quote me on that part. But he was he came up with this classification system, and then he was asked to, the editors wrote back and told him, you need to be able to describe, so it's not only good enough for us to just look at these 4 parts, but how do we know that they're actually broken, or how do we know that these parts need to be managed? And we look at two things, displacement and also angulation, okay? So for a part to be considered a part, it needs to have either 1 centimeter displacement or 40 to 5 degrees of angulation. And why is that important? Any fracture, right? If you look at this, for example, I know it's not an X-ray, it's a diagram, but let's imagine this is a real fracture, right? And you see two fracture lines, you would think you could call this 1, 2, 3, right? 3 parts, because I see 3 kind of segments of the bone, if you will. But the reason why we don't call it a 3-part fracture is because there's no displacement, right? Everything is an anatomic reduction. Nothing has moved. There's a fracture there, but do I really need to be aggressive? Do you guys, I know we haven't talked about treatment, but do you think I need to be aggressive in managing something like this where it's anatomically reduced, has not moved at all? No, right? So the something is considered a part. For example, here, this greater tuberosity is a part. Why? It's because it has at least 1 centimeter of displacement, okay? In terms of management, we'll talk about this later. The greater tuberosity has a different cutoff in terms of if we accept it in terms of treating it non-operatively versus operatively, okay? But for now, overall, if you guys want to remember something, if someone ever in the future asks you about, a proximal humerus fracture and determining a part, it's 1 centimeter of displacement and 45 degrees of angulation. Angulation just means that it's kind of angulated or facing the wrong direction, okay? So when we look at these 4 parts, right, this is considered a 2-part. Because what's fractured off here? The greater tuberosity, and that has 1 centimeter of displacement, and then I have the rest of this, right? So there's 1 part and 2 part, okay? We look at a surgical neck fracture, right? The fracture is through the surgical neck, and then it's still a 2-part because I have this, shaft, and then kind of everything else is 1 segment, okay? Same thing with a lesser, which is kind of a little bit less common for you to have an isolated fracture of the lesser tuberosity, just kind of where it is anatomically, right? Most people, if they're going to fall, or if they have any sort of direct impact on the shoulder, it's kind of all coming to the outside, okay? So that's why. If we look at a 3-part fracture, that means I have 2 fracture lines. Here, where are the 2 fracture lines? I'm gonna cover this one. Where? Surgical neck. And where? Great. How about here? So, sorry, surgical neck and what? Lesser. Okay. Again, the lesser is always more rare. And then the classic 4-part kind of near proximal humerus fractures where you have all those 4 segments that we talked about in their own piece. Like they're not conjoined or reduced or anatomically where they're supposed to be. Okay, so which piece is this? The articular surface, right? Okay, yeah. Does that make sense? Okay. Since this classification has been out, they've made some modifications. These 2 are kind of been added on. One that you could commonly see is something called a head split, where it's exactly what it describes, right? It's through the articular surface, but now you have a fracture line that extends. So your articular segment, instead of being in one piece, which we commonly refer to as one of the parts, it's now in 2 segments. So it's important, again, if I'm calling my attending, to tell him if I have a 2-part through the surgical neck versus I have a 2-part with a head split, right? Because now they understand that fracture line is extending out through the head. Cool. Any questions about this?
Why is that not a 3-part?
This. So again, it's the parts are all referring to those 4 segments, right? So it's again the same reason this is not a 3-part. It's because it's reduced, right? We look at the relationship of kind of these 4 segments. Near when he initially classified this, just came up and looked at those 4 parts specifically. Later on, again, these classification systems are never perfect for one way or another. So they added on kind of a descriptive factor to say, here's a head split, but it wasn't originally included in kind of like the 4 part. It's kind of semantics at that point, but again, the whole purpose of this is to be able to describe a fracture consistently. And this is, for example, one of the common fracture patterns that is seen and that wasn't originally described by NEAR, so they included it as part of the classification system. Okay. Which of these do you guys think has the highest risk of AVN? 4 part, right? Okay. And that's because the articular segment, this part, is really, there's something called, outside of the scope of this talk, but you could look it up later. There's criteria about this articular segment and the length of this piece specifically that they've done studies on over time to kind of look at the relationships of fracture patterns and assessing for risk of AVN. Okay, so anytime you have disruption of this articular segment, that's when you're at risk of AVN, kind of because that's where the circumflex arteries are. Okay. All right, so assessing proximal humerus fractures. Okay, so what do you think we need to talk about, right? The ED, you guys are all PGY1 residents now. The ED calls you and they say, hey, there's, 30-year-old guy, motorcycle accident. He's got like this shoulder fracture. That's literally how they call. I'm not making this up. Okay. So first question you're going to ask them is what? How do you know this person has a fracture? Well, the first way to tell something's broken.
X-ray.
X-ray. All right. So we're going to get some X-rays. All right. So for us to learn how to look at X-rays, there's some common types of imaging of the shoulder that give us different views. So I thought this was good to include. It's a good review. So the first one here on everyone's left, okay, so we're looking at something called a true AP or a Gracie view. If you would imagine, if you guys look at your shoulders, right, is your shoulder in kind of like this straight 180 in relation to your clavicle and everything else? No, there's a little bit of rotation there, right? So for me to get a true AP, which means I'm looking directly at the shoulder joint, I need to have my beam kind of match that, right? If I'm looking at it head on like this, am I going to catch the glenohumeral joint? Or no. So I need to bring it, the Gracie view, which is a true AP of this glenohumeral joint, kind of brings that at 35 degrees, okay? And then that way the beam, instead of facing like this, kind of a little bit angled, and it brings that joint head on, okay? And what do we see? Here's your humeral head, right? What part is this? Greater, right? And then this right here,
Lesser.
Remember, we said it's a little bit more interior. What is this where you kind of see this like scarring? Right? And then somewhere around here, right? There's no like specific line, but it's kind of this area where we refer to as the surgical. Here's your glenoid, right? Here's clavicle, acromion coming from the scapula, right? And here's your glenohumeral joint. So this is what it looks like. Gives us really good view. This one is called an axillary view, okay? So the axillary view, you're kind of, if you would imagine, you're looking right at the axilla, right through this view right here. And the way we do that is we bring the shoulder to 90 degrees of abduction, and then your elbow is also 90 degrees flex. So if this is fully extended, here's at 90 degrees, and the beam is looking right through this way. Okay, sometimes it's most likely done when the patient's laying down, right? So if you would imagine I'm on the table and I just bring up my arm like this, and it gives the beam direct view of the axilla. Sometimes these are kind of confusing to look at, right? Because you don't know what's posterior and what's anterior, right? But if you kind of focus on your articulation, right? You see the humerus. What is this? Glenoid, right? So is the glenoid anterior? Think about it. Which part of the glenoid here is anterior? Look at everything else. What is this? coracoid. Where's the coracoid? Right here, right? Anterior. So this is my anterior, this is my posterior, and here's the rest of the scapular spine. Okay, does that make sense? So these, if you obviously x-rays don't come labeled with anatomy, right? So if you're ever confused to get your bearings straight, you just kind of look at anything else that might tip you off as to where you're looking. Okay, so those are two of the views. Here are some other ones. Okay, this is a pretty common one. It's called a scapular Y. Okay, so what do you think we're looking at with the scapular Y here? Or where do you think the beam is? It's okay to guess, don't worry about it. Yeah, so like lateral, right? Yeah, exactly. So the way they do this is that you kind of are facing, if you're in front of the beam, in front of the plate, right? And you bring your arm in, internally rotate, and the beam is kind of coming from the side here, a little bit from behind you, and it's aiming directly on, right? So now I'm looking at the humeral head directly on a lateral view. And you guys know the scapula, there's a part that's anterior, comes to the front, and there's a part that's posterior, and then there's the scapular body, right? So when we're looking at it laterally, you're looking directly onto the scapula, and you're also getting a lateral of your humeral head, okay? So again, hard to tell what's anterior, what's posterior, but if you kind of focus on where things are, so we know this is the humeral head, right? This is the scapular body, right? Here's the inferior pole all the way at the bottom. And then here, what comes up and wraps from the scapula? So, yeah, outside of the bone, just part of the bone.
Scapular spine.
This is the spine right here, right? So then what wraps towards the front and kind of articulates with your clavicle? Yeah, this is your AC joint. So what part of that is the A? The chromium, right? So that chromium you see here wrapping to the front. You see here, this is what? Clavicle, right? So if you know this is your clavicle, you see the part that's articulating with it, this has to be the chromium, right? And that's kind of, again, how you get your bearings straight. The other part that protrudes toward the front is what? Coracoid, okay? So that's the scapular Y, it gives us the lateral view. And then one view that we kind of, this is more related to shoulder dislocations, is called a Velpo. And the way this works is that the patient's kind of leaning a little bit backwards and the beam is kind of aiming head on. And this helps us to look at where the humeral head is in relation to the glenohumeral joint, or in relation to the glenoid within the GH joint, right? Because if a shoulder is dislocated, then you could see it inferior or posterior in relation from this view. Another one that we do that's after a dislocation because, you know, we're worried about them dislocating again. Sometimes you'll see this is called a transthoracic, where let's say if I'm like laying down in bed, right? And this is my shoulder that's dislocated. I don't want to have to do this Velpo where I'm moving the patient around in their arm because I don't want them to dislocate again. So what I could do is I could lift this arm up and then shoot an X-ray from the opposite side of the body through the, you know, the front of the body here in the chest, and then I'll be able to get a similar view. That's why it's called transthoracic, right? Any questions about that? Cool. All right, so we got some X-rays. Now you're going to see the patient. You believe the ED that there's actually a fracture because sometimes they call you and tell you something's broken, there's nothing broken, or they'll tell you, for example, they'll call you about like a knee and tell you, oh, the knee's broken. Well, the knee has 3 bones, right? Like, or 4, depending on if you see the fibula or not, right? So you just have to look at your own imaging. Rule 101 of orthopedics, don't believe anything anyone says. You have to see it with your own eyes, okay? So you see the X-rays, okay, there's a real, you know, proximal humerus fracture. I want to do something about it. Now I'm going to go see my patient. What am I looking out for? What am I testing? What am I asking them about?
Range of motion.
Okay, so range of motion. All right, what else?
Muscle atrophy.
Think something's going to atrophy. That's a good thought, but if someone has a fracture and they come to the ED right away, you think it's had time to atrophy? Probably not. But that is something that I look at in follow-up, right? Over time, if someone, we'll talk about this later, has any like non-union or something like that, and they haven't been using their arm, yeah, that's something I'm going to assess for, especially the deltoid, because that's the number one thing you see. Deltoid atrophy. That's a good thought. What else?
Pain or
Okay.
sensation.
Pain, what?
Sensation.
Sensation. Blood. Okay, yeah, blood supply, right? What else?
Very close.
Yeah, number one thing, I walk in there, I'm looking at, every aspect of their skin before I even touch the patient. Is this open or not? Is there any source of bleeding? Is there anything that's open, right? That completely changes everything, right? Outside of the scope of this, but open fractures, almost always, they need two things like the second they walk into the ED. What do they need? Antibiotics and Tdap shot, always. Okay, those are they call you, the ED calls you, tells you have an open fracture. Before you even take down the patient's name or anything, did you give ANSEP? Did you give Tdap? The literature has shown that the number one predictor of outcomes in open fractures, no matter where, is time to antibiotics. Okay, that's always okay. So we're gonna go do our exam, right? So this is what we're gonna look at. First, I'm gonna talk to the patient, find out what happened. Hey, did you fall? Have you ever injured this shoulder before? Have you ever had pain in here before? Get all the history, right? It's not just because someone had, a motor vehicle accident or an injury, doesn't mean that there could have been something before that we could have missed. I'll tell you for an example. Recently had a kid come into the ED, football game. Someone stepped on him and he broke his tibia, right? We got x-rays and there's this huge bubble inside of his bone, and it's like something called a non-ossifying fibroma, right? That predisposes him to a fracture. So nobody ever knew about it. Nobody ever thought that he would have anything. You wouldn't think so, but you kind of always ask patients, has this ever hurt before? Have you ever had an injury here before? Because that could give you clues that maybe something else was going on prior, okay? So we're gonna ask them about their pain, check for any swelling, check for any open fracture. It's kind of rare for a proximal humerus fracture to be open, unless it's like a blunt injury or something like that. But definitely number one rule of orthopedics, no matter what is broken, I'm checking for an open fracture. Next, I'm gonna, obviously check, after I look at everything, I'm gonna do my neurovascular exam. Before I actually have them range, I want to make sure that all their nerve function works. What do we say is the most common nerve injured? Axillary. So what am I going to ask them to do? AV duct. And then what else am I going to check for? Sensation where? Okay, right, the lateral aspect here. Am I only testing the axillary? No. What else am I checking? Everything, right? Everything that feeds into the upper extremity. Whenever you see someone with a fracture, basic principles are, even if it's something in their leg, right? I'm checking the whole leg. If it's something in their arm, I'm checking the whole arm. I'm also checking for pain and swelling anywhere else, right? I'm not just checking the shoulder joint. The rule of orthopedics, and you'll hear this, we teach our ED colleagues all the time. If you're going to get imaging of the joint below and the joint above, okay? And you'll hear this a lot. Just because something is obviously broken, let's say it's a humeral shaft right here, I'm looking at the shoulder, I'm looking at the shaft, and I'm looking at the elbow, okay? And then when I go examine the patient, I'm also checking their hand and checking their wrist. And if there's something that, is noteworthy on my exam, and I'm going to get more imaging of that. You never want to miss an injury. That's how you look like a bad resident, and that's also not good patient care, right? Number one thing we care about is making sure our patients are safe. So you never want to send anyone home with an injury that was missed just because you kind of overlooked it. They say, oh, doc, my wrist kind of hurts too. You do an exam and they're very tender, but you make nothing of it because there's an obvious fracture at the shoulder, right? Don't be dismissive of these kinds of things. All right, so we're gonna test the entire upper extremity. We're gonna check pulses. We're gonna check the most common nerves distally, which are, what am I checking for distally?
Either the older nerves.
Median, ulnar, radial. How do I check radial motion?
Extension.
Okay, wrist extension, or just to ask them to give you a thumbs up, right? If I assess distally, wrist extension is correct, but if I assess distally, I know likely everything proximal is intact, right? So that's why we always, there's three things that we ask for any upper extremity injury, or kind of is, I ask patient, give me a thumbs up. That's what radial, PIN specifically, okay? And then I go like this, what's this? What am I doing here?
Median.
Okay, and what am I flexing? Flexing the,
Thumb extension.
yep, exactly. No, some
Flexion.
flexion, right? So this is the AIN, which is from the median nerve, and then the last thing I'm asking them to do is go like this. Yeah, thoracic, right? Exactly. And then and that's ulnar nerve. Okay, good. All right, so I did my neurovascular exam. And then I'm gonna give them some pain medication. And next thing I want to do is I'm gonna try to get some sort of reduction. Okay. If it's obviously out of place for a proximal humerus fracture, it's kind of a little bit, we don't typically need to reduce anything, and this is kind of, again, outside of the scope of this talk, but what do you see here on this? Who could describe this fracture to me, or this x-ray? Go, do your best. What are we looking at? Left or right? Let's start there. Left. Good job. All right. What do you guys see? Does it look normal? Let's start there. It doesn't look normal. Where do you see something abnormal? Okay, right. So you could say, and what kind of view are we looking at? Right, a gray sheet or an AP, right? So I'm looking at an AP of the left shoulder, right? And I see what looks like a fracture through the surgical neck. Okay, does it look anatomic? No, it's closed, but it's not anatomic. And we also see some what? What is that supposed to be here? No, right? So that tells me there's some comminution or some fragments that are out of place. Okay. In terms of treatment plans, again, I'll kind of skim through this because it's outside the scope. Most of these fractures are treated non-operatively. If I see someone with a proximal humerus fracture and it's closed, they're neuro intact, not worried about anything else, most of the time we could give them a sling. And that is based off of a couple things, right? Displacement, when we talk about the amount of displacement that we look at, 1 centimeter. However, for a greater tuberosity, whenever we're looking at non-operative versus operative, it's 5 millimeters. So it's half of that. So it's the third number you kind of need to remember for these fractures. Okay, so it's 1 centimeter, 45 degrees of angulation for describing the fracture. But when we're talking about the greater tuberosity specifically in terms of managing operatively versus non-op, it's 5 millimeters instead. Okay. And then obviously if patients are elderly, kind of like that, which a lot of these fractures happen in the elderly that are frail, kind of end of life. If they're not good surgical candidates, no matter what, then we're not even going to talk about it, right? We'll give them a sling and send them home. If we decide to operate, there's some different options that we have. CRPP is closed reduction percutaneous pinning, where you kind of get your things without opening the skin, get things into an anatomic alignment, shoot some pins in, leave them there. There is an intramedullary nail, again, less common nowadays to nail, kind of like we do for hips and femurs, that goes down the shaft of the humerus. There's an open reduction internal fixation where you do some plates and screws, or arthroplasty, which is kind of a hot topic for proximal humerus fractures, because more and more commonly, depending on the type of fracture and the age and kind of where people are at and their rotator cuff and things that we don't need to discuss here, shoulder arthroplasty is kind of a more up and coming way of treating these types of fractures. Okay. So this is a patient that we had here. I don't know, did we show the initial? Oh, okay, yeah, so this is a patient that was described here in one of our fracture conferences on Mondays of a patient, that 68-year-old female. She came following a ground level fall. She had, this is actually the same as this is the same patient. She had a ground level fall. She was initially treated non-operatively. Again, it's the fracture through the surgical neck that is most what you could easily see. She was treated non-operatively. This is actually when she came back. And you would have expected some sort of healing by then, but she had a non-union, and she later went on, wait, I'm going backwards, sorry. She later went on to have a reverse total shoulder. Okay, why is it a reverse? Why is it called?
Round part is on the shoulder, not the glenoid, not the humerus.
Exactly. Okay, so a normal shoulder, right? What's the round part? It's your humeral head, right? And a total shoulder arthroplasty, you would see exactly that. It would look like the sphere would be on the humeral stem, kind of at that after that neck, and then your glenoid would have a cup instead. But this is a reverse, and you guys could look this up later, but there's a whole history and reason why the biomechanics of a reverse total shoulder actually work well. And it's specific for patients who have bad rotator cuffs. Okay, so rotator cuff arthropathy is one of the indications for reverse, especially in the setting of a proximal humerus fracture. Okay. Some complications that we look for when patients come back are if they have any mechanical failure, so any blocks to motion, because again, things could kind of heal inappropriately. You look for AVN. We talked about those 4 parts. They have almost a 20% risk of AVN. Nerve injury, kind of, we'll get back to that UWorld question. If they had any dislocations, malunion, non-union, what's the difference? Yeah. Yeah, so malunion is when you have some sort of healing, bony healing. However, it's non-anatomical, right? Non-union is just complete failure to develop any like fibrous or bony ossification. Okay. Post-traumatic arthritis, something that we talk about for any fracture. Patients who have broken bones are predisposed to early arthritis, especially if it's within the articular surface, because that's where a lot of people most commonly have these fractures, and it's also where arthritis develops, right? And then infections, if it was like any open injury or anything like that. Well, let's practice. Okay, this is again a patient that was described here in fracture conference by one of the senior residents. So what do we see here is a 69-year-old male who's right hand dominant, who presented with actually bilateral proximal humerus fractures after an injury of bike. I guess he crashed into a motor vehicle. So are we looking at the right or the left here? Okay, all right. What do we see? What kind of views are we looking at roughly? The first two are a little similar. It's not the same. Sometimes they shoot more than one of the same view to get a better shot. Was that what?
Lateral.
Okay. And then what's this one?
Lateral.
Oh yeah, right. That scapular Y that we talked about, right? Which is the lateral. Do you guys see anything wrong? Do you see any fractures anywhere? For the sake of time, I was kind of showing you guys. I'm following the one way to look for fractures when things aren't super obvious. I mean, this is a little grainy, obviously it's a picture of a picture, right? But if you follow the cortex, right? So I'm following this, it's nice and smooth, continuous all the way around. What happens when I follow the cortex here or here? Do I see any disruption of the cortex? Yeah, right. So this, your humeral head is here, and your cortex is running and stops right there, right? So that you have a surgical neck fracture. Sometimes bones don't always break in 2 pieces with like a diagram, so you have to really scrutinize x-rays. Okay. This is another one. What do we see here? The right shoulder this time. What are we looking at? What do we notice? Where's the humerus? Does it look like it's where it's supposed to be? No, right? So. Again, this is why we get multiple views or orthogonal views to kind of look at things in a 3D way. We get different shots of x-rays so we can piece it together. The humeral head here, look at the AP on the previous slide. Sorry. Look where it is in relation to the glenoid. Now look here. Where's your glenoid? Here. Where's your humeral head? Are they articulating? So that means this patient had a
Posterior dislocation.
dislocation, right? Oh, you can't tell right away on one view, okay, but you can tell on two views, right? So again, this is the scapular Y. What do we see? Where's your humeral head? I know it's kind of fuzzy, but here's your shaft and everything's facing here, right? This is somewhat your humeral head. I know it's hard to see, okay? And you're right. So this is everything's kind of facing anterior here. So it looks like a posterior dislocation, posterior, inferior. Okay. All right. So here's like a quick video to kind of, sometimes these aren't exactly easy to see. That's why we get CT scans, right? I'll show you guys here. So here again is that this is a CT scan. You're imagining the patient laying flat, right? So this is that right shoulder, right? And you see a fracture line here. There's a break in the cortex. And then look on the left, you'll see that dislocation right there. You guys see it? So here's your glenoid, right? And here's your humerus. It's actually anterior. All right, it's easier to see on this is the axial, so then we'll go through the coronal here. Here, this is again the break right here in the cortical surface, and then here's that inferior dislocation, right? And you could see the fractures in different parts. Okay. So this patient was treated with slings on both sides actually, and they went on to do fine. All right. So back to our question. What's the answer? Axillary nerve. All right. You guys are experts. All right. Thank you guys.
Yeah, I just fill out, there's a post survey feedback form.
Also, thank you to Eliana and Talia for setting this up and putting this together. They've been working hard for your education, so all credit goes to them.
No, they give us to come in
Oh,
here.
happy to. Yeah. Anytime.
I know the M1s have an exam tomorrow, so thank you guys for coming and good luck. And you're free to go whenever you finish this survey.
So what is it?
Oh, it's on the
Alright.
There's also pizza, guys, if you want another slice. I think it's my
All fired.
What's that? I'm on neurosurgery and it's like, I haven't really shown it, to be honest. It's like service rotation, so I only go if there's like big cases. There's nothing spine related happening. And 10 hours of brain cases. A little bit. You could, I mean, with the all service rotation depends. Some of them are easier to see. Oh, thank you so much. I appreciate it. Some of them are easier than others. It's kind of,
Yeah.
depends, also depends on the team and the person, like, the red berries, so.
Like result. I
I
just
was
got the
literally just
email.
texting.
I don't even want to. I don't want to look at it either. It was yesterday.
If it helps, that's what scared me into starting studying.
Thank you. Yeah.
Yeah, you're welcome.
I told myself it was gonna give me a jump scare. I needed it. Take a look. You know what? I just think I have to be better. I'm like, I need to utilize the morning hours just to get a couple of.
Yeah.
If I don't do it in the morning, I'm just gonna get overwhelmed by like.
I used to sleep in, just wake up and then go to like 2 in the morning.
Oh,
That's
God.
fine.
You're the night, you're the night.
I've always been that way. Though.
Yeah.
Hi, how's it going? Sorry.
I'm good.
Good.
I saw your,
Oh.
just.
Oh,